cover up because when I was actually trying to make the whole presentation in a simple manner, I went on making and there I went on adding more and more slides, but I'll still try to make it a little interesting. So I'd like to share my screen with all of you. So is my screen available to everyone here?
Yes, ma'am. It is in presentation mode also. You can start your presentation.
Okay, thank you. So we're talking about pain management today, and I would like to discuss first about, starting with definition of pain, going to pain pathophysiology a little bit of how to assess pain, and then managing pain with some a little more importance on opioids, morphine and fentanyl, and pain in respiratory illnesses, because I know that I'm going to talk about more about respiratory diseases, and along with that presenting a little bit of existing evidence that is there for us to remind us that their pain is an important factor to decrease the quality of life of any person who's going through a respiratory illness. So it is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Henceforth, it is an unpleasant bodily sensation. It is an experience threat which is associated with this sensation, and it is a negative emotion based on this experience threat. So you can understand how difficult it must be for a patient who's actually going through pain, who is telling every time that I have pain, and who has not been understood well. So here we need to understand the unpleasantness of this bodily sensation and the threat that and the negative emotion that is associated with this particular sensation. About pain pathophysiology, in the year 1664, there was this particular concept that came up, and it's a simple line diagram that would show the pain transmission from a source, maybe a kind of a fire that is in the picture, and it travels through the leg, somewhere through the spinal cord up to the brain. So this was the historical perspective. But now we know that there are areas of pain processing and areas of pain modulation also. As you can see in this picture, there is a pain source, and which is perhaps doing some kind of insult to the finger of the hand, and that is a kind of a noxious stimuli, and it's initiating an acute physiological pain. And then there is stimulation of the nociceptor, and the impulses are being transmitted via the peripheral nerves to the dorsal root ganglion of the spinal cord. These messages would actually travel via the spinothalamic tract, and that is an ascending pathway to the cortex of the brain, where we've got a number of areas of pain processing, and then the pain would be processed, and then as the signals which are inhibitory would be transmitted down to the same hand or the same area of peripheral modulation via the descending tracts. It is, I have tried to make it as simple as possible just to understand how the pain processing and pain modulation happens. So there are certain kind of neurophysiological consequences that happens when a person goes through pain. So these are peripheral sensitization, something called peripheral recruitment, and then something called the central sensitization, which goes up to a central recruitment. So let us see what is peripheral sensitization. So what happens is that during an insult, as we saw in the previous picture, there's an insult to the hand, perhaps the finger. There is a sensitization of the nociceptors in the peripheral nerve, which causes a release of certain analgesic mediators, and mainly the prostaglandins, potassium, histamine, leukotrienes, bradykinin, substance P, etc. Specifically, prostaglandin is the substance which sensitizes the nerve ending so that the other mediators could cause a progressive nociception or progressive pain transmission from the periphery to the dorsal root ganglion. The clinical significance here at this point of time is that the treatment with NSAIDs may prevent nociception from other pain-producing substances, because we know prostaglandin synthesis is inhibited by NSAIDs. So this is peripheral sensitization. If peripheral sensitization, or if the pain insult is not stopped here, what happens is that there is a recruitment of certain silent or slow, sleepy nociceptors. As you can see, the red colored lines in the peripheral nerve, those are the silent or sleepy nociceptors. They get recruited in the process of sensitization because the prostaglandins and other mediators are acting on the insult. And generally, these silent or sleepy nociceptors, they actually do not normally respond to a stimulus, but they are activated in the inflamed tissues. So as we know that when there is an insult in one part of the body, there is a process of inflammation, and hence if the inflammation and the insult is not stopped, this silent or sleepy nociceptors would get recruited and act on taking the impulse forward to the dorsal root ganglion. Henceforth, both the mechanism of peripheral sensitization and recruitment, they can be triggered and maintained by the release of these substances in the periphery from the nociceptive terminals. Now, what happens if we do not treat the patient or the pain at this point of time? There's something called the central sensitization. What happens is that the CNS is sensitized by nociceptive inputs because from the peripheral nerve, the impulse is transmitted to the dorsal root ganglion, and the ganglion transfers it to the dorsal horn, from where it goes up to the cortex through the spinothalamic tract. And here in the areas of pain modulation in the cortex, the central nervous system gets sensitized by these inputs. The C fibers, which are responsible for a delayed and dull kind of pain, are repeatedly stimulated because of these inputs. And hence, there is a progressive increase in the number of electrical discharges of the central nervous system. And something called a wind-up phenomenon happens, where the whole of the central nervous system gets involved in pain modulation. This generally goes on to the recruitment of the central nervous system if the pain is left untreated. And as a result of all these changes, a phenomenon called the secondary hyperalgesia comes, which is an increase in the pain sensitivity when a noxious stimulus is delivered to a region surrounding but not including the zone of injury. For example, if there is an injury in the elbow joint, the whole of the shoulder joint and the whole of the hand will start paining, even if you are not actually touching on the injured part. That is called a secondary hyperalgesia. And this is a result of central recruitment, which is in fact a process because of untreated pain at the periphery. So this is a small idea about the pain pathophysiology. So based on this, we can classify pain in two types. One is called acute pain, another is chronic, and it is self-explanatory. But there is a difference, and the difference is that acute pain is considered to be a symptom of a disease. It has a positive effect because it gives us the signal that we need to treat acute pain because it is a symptom of one disease. It is associated with certain signs like pupillary dilatation, sweating, increased BP, tachypnea, tachycardia, etc. But chronic pain in itself is a disease and not a symptom. It has a total negative effect on the personality. It is, there is no sign as in acute pain. It is, there is nothing that actually tells you that the patient is in chronic pain. It causes certain disturbances like sleep disturbance, anorexia, dysplasia, anxiety, and so on and so forth. So chronic pain is considered a disease. Acute pain is considered a symptom. So when we talk about pain management, we generally are talking about managing chronic pain. Types of chronic pain: if it is limited to the periphery or the peripheral nerves, it is the nociceptive pain. And if it involves the whole nervous system, starting from the peripheral nerve to perhaps central recruitment, then it is called a neuropathic type of pain. Nociceptive pain can be divided into two parts, mainly the visceral part and the somatic part. And the capsular pain, bowel pain, cardiac pain, all comes under visceral pain. The bone pain and the soft tissue pains are generally called as somatic pains. Neuropathic pains is definitely due to nerve compression or injury. And this injury or compression may occur in the peripheral nerves, it may occur in the sympathetic system, or even the central nervous system. So manifest as, burning, pricking, aching, soothing, lancerating type of pain. And that is what we call the nature of the pain. There is usually a neural or a dermatomal distribution of that pain. For example, if the patient is, suffering from, say, herpes zoster, then you know how the infection occurs. If it is in the thoracic nerve, it might have a kind of a neural or dermatomal distribution. And it is always associated with hyperalgesia and allodynia if not treated. So how do we generally assess pain? I've tried to make the assessment as simple as possible. The main mantra of assessing pain is review, review, and review. So you need to review the pain, the chronic pain, before and after giving medications. We generally do it once a day. We may also do it twice or thrice a day also if it is needed, because you need to understand what the patient says. Pain is always a subjective phenomena. We cannot do a CT scan to find out how much the patient pain, the patient is complaining of pain. Henceforth, we need to ask the patient, is your pain better? How are you feeling today? So that is how we need to assess. So you review, review, and review. As we take, the history of a present illness, since chronic pain is also a disease and an illness, you take the history of the pain. You take a general history also. You ask about the response to analgesics that he has already taken. Any other treatment, for example, radiation, for example, any other regional blocks, or any injection that he has taken before, any associated physical symptoms, interference in his daily activities, and then examination of the area of the pain and the general examination of the patient. And you do certain investigations also as may be prompted. You may order a chest X-ray, you may order a CT scan, whatever is important at that point of time. So when we talk about pain history, we generally follow this very nice mnemonic of OPQRST. So O stands for occurrence or frequency of that pain episode. P stands for precipitating or provoking factors. Ask the patient what precipitates his pain. Is it, by walking? Is it by running? Or is it by, lifting something from the floor? And how is the quality or character of the pain? We'll discuss about the quality in the next slide. Then radiation to pain. Radiation of the pain means if the pain, suppose the pain is in the back, does it radiate to the lower half of the body, to the lower limbs? Coming to the site or area of the pain, ask the patient to pinpoint with one finger where the pain is. And you will be surprised to notice that he definitely points his finger towards that particular site. He'll definitely pinpoint it that this is the area, this is the site that I have been having a pain. Then you ask about the intensity of pain, and that also we are going to discuss in the next slides. And T stands for the duration of pain, since how long, and the temporal factors like, is it more in the evening? Is it more in the morning? Is it after taking food or something like that? So Q for quality of pain. As we know, it is nociceptive and neuropathic. Nociceptive is wound-like, aching, gripping sensation. And when it is neuropathic, the patient will actually tell you that it's numb, kind of lancinating or shooting kind of a pain, feeling of raw skin, or chilies been rubbed, and kind of a burning sensation. And sometimes he would also tell you that there are a bag of worms in this particular area, some crawling of ants. And these are all description of the quality of pain. Coming to the intensity, we generally measure the intensity of pain by certain scales, and the most widely used scales is the numerical pain scale. For children, we use the Wong-Baker Faces pain rating scale, and there are certain other scales like the finger scale, and I personally sometimes use the coin scale to ask my patients, those who are from the lower strata of the society, कि एक रुपया में कितना दर्द है, and the patient will actually tell me एक रुपया में 50 पैसे का दर्द है or 75 पैसे का दर्द है. So these are very simple yet very validated and great tools to actually give you the intensity of pain. And there are detailed assessment questionnaires like the McGill questionnaire and the pain inventory questionnaire, but I'm not going into those details. I'll show you the pain assessment tools that we generally use. This is a 5-finger score where, 0 is no hurt, then it goes to hurts a little bit, 2 fingers would hurt little more, and so on till 5. This is the faces score where, the smiley actually are shown to the kids, and they would pinpoint you with their fingers how much pain they have. Interestingly, the number score is the widely used scale, and from 0 to 10, where 0 is no pain, 5 is perhaps 4 to 5 is moderate pain, and 10 is the worst possible pain. So you can use a combination of all these tools also. If you're not getting, the proper input from the patient, you can use a combination of all 3 of these scales, or even you can actually, through your experience, by asking pain to your patients, you can actually design your own pain scale, pain assessment tool, and that would be validated for you, because you are taking that particular history from the patient and you're zeroing on one particular tool. So this is a body chart where we generally ask the patient to, show the area where the pain is, and this also helps us in, remembering where the pain was. And when you review the patient later on, you can actually see if the patient, if the pain has reduced, or has it moved to some other side, or is there a new radiation that has happened. So this body chart also helps us a lot in assessing pain. Now, based on the assessment and based on the pathophysiology that we have come, we have gathered from the patient, we come to the management part of the pain. So a basic principle is always look for the cause of the pain and correct the correctable. Is the cause of pain a recent irradiation or a recent chemotherapy or a surgery? Is the cause of pain because of some recent injury, or, not even recent, if it is a long-standing, pain that has happened because of an accident that was 3 or 4 years ago? Is that the cause? So look for the cause and you correct the correctable. Principles of pain management generally remains the same. It is prompt treatment. Whenever the patient comes to you, come to know about the pain, you have to initiate treatment then and there. The most important underlying principle is prevent recurrence of that pain. You set realistic goals. For example, achieving a good night's sleep. The patient would generally, in cancer, the patients that we get, they complain, I've not slept properly for the last 1 month. And that is why our realistic goal at that prompt treatment would be to give a good night's sleep to the patient. And that is a realistic goal which we can actually achieve. The medications would be definitely by the mouth, by the clock, and by the ladder. And when we say ladder, it is the WHO ladder, which we are going to discuss in our next slides. And when we say it is by the clock, I mean that we have to avoid the as and when required dosages, because it is not an acute pain, it is a chronic pain, which is a disease. It has to be an individual centered. You have to tailor cut the whole prescription of pain medications, and also look into the renal and hepatic dysfunctions, because many of our patients might be elderly patients with renal and hepatic dysfunctions. Do not forget the adjuvant drugs. So I'm just coming to the next slide, where the treatment will be from the non-pharmacological methods to the pharmacological methods, going on to the interventional techniques, and many times a combination of all these 3 things. Excuse me. I'm not going into much details about non-pharmacological methods, but I have to say that they have their own place. They have their own importance in pain treatment. And I sincerely believe that you all may have gone through the non-pharmacological methods, physiotherapy and heat application, etc., etc. Coming to the WHO analgesic ladder. So this analgesic ladder has been designed by the World Health Organization, and it gives us the guidance about the usage of all kind of analgesics that are available for pain control. For step 1, it's for moderate, it's for mild pain, and you start with paracetamol or an NSAID, for example, ibuprofen, aspirin. And if the pain increases to a moderate range, you have found out that the patient has a moderate pain, you escalate to the step 2, which is a mild opioid. The mild opioids are codeine and tramadol. But then you have to consider using the non-opioid, which is paracetamol or NSAID, in combination with the step 2 drugs. Right? And here, if the patient doesn't respond to the step 2 drugs, or he has more pain, you escalate the dosage to the step 3 drugs. And step 3 drugs are strong opioids for moderate to severe pain, and they are morphine, fentanyl, etc. But always remember that you must not combine a mild opioid with a strong opioid. There's no point using that. Step 2 and step 3 medications must not be combined for any kind of pain treatment. But step 2 and step 1 can be combined. Step 3 and step 1 can be combined. Do not forget the adjuvant drugs, which are steroids, antidepressants, anticonvulsants, muscle relaxants, antispasmodics, etc., etc. Always give the analgesics by the mouth, by the clock, by the ladder, as we have, and do not forget the interventional pain managements that should always be taken into consideration. If it is a cancer patient, and if you think, by discussion with your team of radiation oncologists that radiation can be helpful for this patient in reducing the pain of that patient, please do consider that. So all these things should be taken into consideration. So these are the drugs in the WHO ladder. The non-opioids are basically paracetamol or acetaminophen, ibuprofen, diclofenac, and other coxibs like etocoxib and other drugs. In the step 2 drugs, we have the weak opioids. The step 3 drugs are the strong opioids, and these are all the, on the right-hand side, you can see the adjuvant drugs. So coming to the first 2 steps of the ladder, what do we do in the first 2? What are the main medication that we find in the 2 steps of the ladder? Basically, the non-steroidal anti-inflammatory drugs. And, we have something called the preferential COX-1 inhibitors, the non-selective COX inhibitors. There are a huge range of NSAIDs with you to, start advising to your patients. But then, having said this, the indications for NSAIDs would always be the somatic nociceptive pains, which is from mild to moderate intensity, basically inflammatory in nature, and the kind of bone pain that a patient might exhibit because of bone metastasis. Certain precautions that we need to always take care is the irreversible platelet dysfunction with aspirin. So classical NSAIDs except diclofenac cause reversible platelet dysfunction, and hence are more preferred than use of aspirin. where there is a underlying platelet dysfunction. When we talk about the heart, NSAIDs may worsen heart failure. They may increase the risk of recurrent MI in patients with CAD. They might raise the blood pressure. Henceforth, the suggested non-selective NSAIDs for patients with heart disease or a history of MI with CAD is naproxen. Do not use any other NSAIDs. For kidney diseases, NSAIDs may cause sodium and water retention, as we know that. And it may also result in reabsorption of potassium, and that leads to hyperkalemia and increased BP. So for kidney diseases, we will not use NSAIDs. We will avoid NSAIDs. And as we all know, for GITs, there's an increased risk of GI bleed, especially when it is being used with warfarin. And there is an increased risk of peptic ulcer disease also when used with glucocorticoids. So NSAIDs are large in numbers. They are very good. They are, the first line of treatment for somatic nociceptive pain of mild to moderate intensity. But then we have to exercise the precautions that are needed for platelet dysfunction, the heart disease, kidney disease, and GIT. Coming to the step 2 medication, which is an important medication, very widely used, tramadol. Unfortunately, it is associated with seizures when the total daily dose exceeds 400 milligrams. So we need to understand how much tramadol is needed and what is the background of this particular patient, because if the patient has epilepsy, has had a head trauma, has a raised ICD, as seen in many conditions, we generally will not use tramadol. And please do not use a rapid IV injection of tramadol because it can precipitate seizures. Generally, we do use tramadol, but we dilute it with around 10 ml of distilled water and give it in a very slow rate. So that is how we do it. This is a opioid potency chart where the ratio generally is compared to that of morphine, where morphine is standard as 1, and the other opioids that are available to us, the potency ratio is being compared to morphine. So the highest potency is that of fentanyl, which is around 100 to 150. And the lowest would be for codeine, tramadol, and dextroamphetamine. So when you introduce strong opioids for an ongoing pain, you're escalating your medications from the step 2 to step 3. What are the general indications? It is obviously the pain which is unrelieved by non-opioid analgesics, and the starting dose would depend on previous exposure to opioids, the age of the patient, and the severity of pain. Always remember that continuous pain requires continuous or background analgesia. Something about morphine. It's a very interesting medication. It is, it is the most important opium from the poppy alkaloid. And as you can see in the left-hand side picture, these are the poppy seeds. Many times, basically in Bengal, the poppy seeds are used. They are also called khaskhas, if I'm not wrong. And they're used for, making curries and all. And it induces constipation and sleep. So whenever you have a poppy seed curry, generally you go to sleep. So Bengalis use it in a very large scale. On the right hand side, you can see that poppy flower, that beautiful poppy flower. And on the middle is the main unripe capsule of the poppy flower, which is, you can see some cut marks, I think may have been made to extract the white colored liquid. You can see the white color pasty kind of a liquid. And this particular liquid is the most important source of morphine. So this is where, otherwise the whole poppy plant is actually used for extracting morphine. So these are the formulation of morphine. Morphine hydrochloride is available as an immediate release in 10 mg and 30 mg tablets. There are slow release tablets also, which work within a range of 8 to 12 hours. 10 milligrams, 30 milligrams, and 60 milligrams are available. Morphine used for subcutaneous and IV routes are available as morphine sulfate, which is 10 milligram and 15 milligrams per ml of ampules. Little bit about how morphine is absorbed and excreted. So morphine is generally, it's a weak base. It is widely absorbed by the oral route. Henceforth, it generally goes absorbs. It's absorbed properly in the alkaline medium of the small bowel, the upper part of the small bowel. It is a hydrophilic substance, hence it has a slow onset and a longer duration of action. And since there are no evidence of buccal or gingival absorption, we generally do not administer or advise morphine for a sublingual kind of a thing. Many people ask, they think that sublingually it will be absorbed, but sublingual absorption is very, very low. So we do not do that. It is easily absorbed from the upper small bowel. It passes through the hepatic metabolism, and that is the first pass metabolism. It is swallowed, goes to the GIT. In the upper bowel, it's absorbed into the blood vessels and then goes through the portal vein to the liver. And in the liver, which is the main site of metabolism, it is broken down into its metabolites. And then these metabolites are taken to the systemic circulation. So what happens is that 90% of these metabolites are formed in the liver, because the liver is the main part of metabolism. Out of these 90%, the metabolite called morphine-3 glucuronide is the widely abundant one, but it doesn't have any action. And the most important metabolite, which is responsible for pain relief, is only 5 to 10%, which is M6G or morphine-6 glucuronide. So it is excreted by the kidneys by glomerular filtration, and hence it generally accumulates in renal failure. So the clearance of morphine-6 glucuronide in renal failure is decreased, and hence the half-life is increased. So we need to be vigilant about usage of morphine or advising morphine in patients with renal diseases. Fentanyl is less constipating than morphine, and henceforth, it is more used in subacute bowel obstructions also. It is less sedating than morphine, and the opioid of choice in renal failure and hepatic dysfunction, because it doesn't accumulate in renal failure or hepatic dysfunction. It is lipophilic as compared to morphine. It is available as injections, but more widely used for palliative care patients is the transdermal fentanyl patch. It generally forms a depot in the skin, underneath the skin, and effective analgesia occurs only after 8 to 12 hours. And hence, when we advise fentanyl or escalate or if we change from morphine to fentanyl, we have to take this particular fact in consideration, that the effective analgesia after giving fentanyl patch would occur only after 8 to 12 hours. Henceforth, till that particular period of 8 to 12 hours, we will need to cover the pain with either with oral morphine or some other medications, which is equivalent. We need to change it every 72 hours. And that is where the peak, it rises by 8 to 12 hours. It maintains in a plateau and then comes down over the next 72 hours. It is not suitable for titration because the opioid in opioid naive patients, and it is also not suitable for unstable pain. The skin condition and temperature generally affects its absorption. Please excuse me for my dog is actually barking. Please give me 1 minute. Coming to morphine side effects, there's something called adverse effects with therapeutic doses. The side effects are generally the adverse effects that occurs with therapeutic doses. And those are basically constipation, nausea and vomiting, sleepiness and tiredness, itching and pruritus, dry mouth, and urinary hesitancy. So these are the very common side effect that happens with morphine. And how do we take care of them? So constipation occurs in about 95% of our patients, and they generally, it lasts for a long time. And henceforth, we have to use a stimulant laxative like bisacodyl for taking care of morphine-induced constipation. We must not use bulk-forming laxatives because they are going to form the bulk, and there won't be any stimulation to take out the wastage, as it's not actually stimulating the gut to release the wastage. It is forming the bulk, and henceforth it is adding up to more of the wastage mass. And that's why bulk forming laxatives are contraindicated in constipation of morphine. Coming to nausea and vomiting, it occurs in 1/3 of patients in the first few days. It is, if we say few days, it is like maybe around 4 to 5 days of initiation of morphine. It is always self-limiting, and it occurs due to stimulation of the CTZ in the brain. And hence, the drugs, if the nausea and vomiting is too much of a problem for the patient, we must give drugs that acts on the CTZ, and that is basically the D2 receptor antagonist. Haloperidol is the strongest D2 receptor antagonist. We use it in abundance, followed by metoclopramide and domperidone. Generally, in everyday practice in palliative care, we generally use metoclopramide for nausea, vomiting induced by morphine. And as we know, metoclopramide is also a prokinetic, and henceforth, when used in combination with the stimulant laxative, the constipation induced by morphine generally relaxes. So it's a two-way mechanism. By using a stimulant laxative and metoclopramide, you generally take care of both constipation and nausea and vomiting. Coming to the other side effects, which are sleepiness and tiredness, these also occur in 1/3 of patients on initiation, and they are self-limiting, generally do not require to do anything for this. Sleepiness is not drowsiness. It is just, being a little sleepy. But then when the person wakes up from the sleep, he is alert. And the difference between being drowsy is that even if he gets up from the sleep, the patient is not alert. So that is the difference between sleepiness and drowsiness. Coming to another symptom, which is itching or pruritus. Generally, the morphine-induced pruritus is seen when you give a spinal or intrathecal morphine. But then in oral morphine also, there are instances where the patient might complain of certain itching. The mechanism of occurrence of itching or pruritus is still not clear, but it is postulated that there are central receptors like the serotonin 5-HT3 and perhaps D2 receptors. They may have a role in causing this pruritus. Henceforth, we use drugs like ondansetron, which is a serotonin 5-HT3 receptor antagonist, and not histamine blockers. You have to take this into consideration. If you have started a patient on morphine and the patient presents to you after 1 week or maybe after 2 weeks with itching or pruritus, and you have to take this history about how the itching has happened. Has there been any other sources of itching or pruritus? Has the patient taken any other medication for that reason? And has he tried on other medications for the itching? And if these things are going negative, then you have to think on the lines of morphine-induced itching or pruritus and advise the patient on drugs like ondansetron, which is going to take care of that. And we have had pretty good results in taking care of the pruritus. So coming to toxic effects are the adverse effects when the administered dose is higher than the dose required for pain relief, or when the pain has poor response. So there are two extremes to the toxic effects, the occurrence of toxic effects. One would be where the dose which is required is given on a higher range, or which is not perhaps maybe around 16 milligrams is required, but we landed up giving around 80 to 90 milligrams, and that has caused the adverse effect. And when you have actually tried morphine and the pain is not responding to morphine. So we need to understand that only perhaps 40% of pains are responsive to opioids. That is a fact. And that is why we need to evaluate pain, review the pain on a daily basis, on a regular basis, to understand whether or not the pain is responding to the given medications or not. So that is an important learning point here. So what are the toxic effects? The patient generally, show delirium. There may be myoclonus. There may be drowsiness. And as we have experienced, drowsiness is always the first symptom to get exhibited in patients who are showing toxic effects to use of morphine. So I come to the last part of the pain in respiratory illnesses. I've got some amount of research, a little bit of evidence, and I've got certain important facts here. Pain in, there's a review article by Solano et al. And this is considered to be one of the best papers because it has showed, it has studied symptom prevalence in 5 conditions, out of which COPD, cancer, heart disease, AIDS and renal diseases have been taken into consideration. And here the paper says that 3 symptoms have been frequent and universal in all these diseases, including COPD, and which is pain, fatigue, and breathlessness. And the prevalence has been well above 50%. So you understand how important it is for us to take care of the pain in respiratory diseases. Despite their high prevalence, there has been under-assessment and under-treatment of these pains. And this has significant effect on the quality of life of patients suffering from COPD. There are other evidences that have, you can go through these papers. There is something from Bodge et al. In 2010, and they have shown a relationship between pain location, pain intensity, and pain prevalence on the quality of life of COPD. And I think this is the only study that I could find out. There may be others also. I don't have an access to all those studies, but this is an important study and one of its kind, which shows a relationship of the location, intensity, and prevalence of pain on the quality of life in COPDs. And you can go through other, other papers also, which I have mentioned here. It is usually, felt in the chest. Chest pain is very frequent in COPD. And interestingly, they have a musculoskeletal or pleuropulmonary origin. And the causes are postulated to be some kind of a subcostal pain due to diaphragmatic and intercostal muscle fatigues. There may be rib fractures relating to coughing, or corticosteroids induced osteoporosis, because we use a lot of corticosteroids for COPD, and that might induce some bit of osteoporosis also. Pleural inflammation is caused by infection, and infection is, it goes hand in hand with COPD. So these are the causes of pain in COPD, and we need to take care of this pain. In ILD, the main pain location in the patients are seen in chest, the joints, and the limbs. Interestingly, I also found few studies that were for the connective tissue disorder related ILDs, and those have a kind of a background, continuous background pain for the patient. Unfortunately, the chest pains in the causes of chest pain in ILD remains unclear, but they can be related to all these factors that I have mentioned, like the pulmonary loss of elasticity of pleural pleura. There may be some bronchial fibrosis, some vertebral deformity, and so on. So patients with pain in ILD have suffered worst quality of life according to this particular paper. And other psychological deficits would be a combination where like symptoms of anxiety and depression always going hand in hand with the kind of pain the patient who suffers from ILD. So certain myths and facts that can be that we can zero in are that there is a myth that opioids will cause respiratory depression. It is not like that. In fact, there is a excellent paper by McNichol et al., who has, they have said that the patients generally take their medications by mouths, and combined with the normally gradual dose, it is ensured that the respiratory depression is unusual. And they went on to postulate that when respiratory compromise do occur, an alternative explanation should always be sought, like pneumonia, pulmonary embolism, cardiomyopathy, or co-administration of sedating medications such as benzodiazepines. So, my friends, opioids do not generally cause respiratory depression. At least I have been practicing palliative medicine since the last 15 years or so. And I have, advised more than 500 to 600 patients oral morphine. And I have also used injectable morphine. But I have never come across any single patient who has undergone respiratory depression because of use of morphine. So please do not hesitate to use morphine for these patients. Another myth is that NSAIDs should be avoided in COPD because of the perceived risk of precipitating bronchospasm. And that is absolutely a myth, because the existing evidence suggests that paracetamol and NSAIDs should be used with equal care in COPD patients, but that for use in pain at the end of life. I would repeat this, that the use of paracetamol and NSAIDs at the end of life, benefit from ibuprofen and paracetamol is likely to outweigh any kind of harm. So please do use ibuprofen and paracetamol if the patient is at the end of life. Interestingly, another fact that has come up is that ibuprofen may be particularly useful because of its effectiveness for pain of musculoskeletal or pleural origin. I come to the end of this discussion, and I'm open to all questions that I will be able to answer, I hope.
Thank you, Dr. Sanghamitra, for that excellent session. So now the line is open for questions. We don't have any questions now in the chat. Anybody wish to?
Okay, maybe then we can go to.
Thank you, Sanghamitra. I was not allowed to unmute myself, so I was a bit late in thanking you.
Hi, Rajan.
Yeah, hi. So first of all, I mean, it's a very difficult topic to finish in half an hour, 45 minutes and to gauge. But
Exactly.
we wanted you all to experience this, because this is the stepping stone of getting more interested in palliative care. And when we did the non-respiratory symptoms with Vidya, we realized there were so many questions about pain, and we realized that we are never taught about this in MBBS or MD. So it was important for us, and I think now we will start including pain also as a part of our training when we do subsequently to respiratory physicians. Now there is another question. There is one question from Kiran Vishnu about muscle pain and cramps. What would you suggest? First, Sanghamitra, and then I'll talk from my personal experience as to what I do with my mom and elderly in the house. Sanghamitra, over to you.
Yeah. So I would like to reiterate the fact that the principles of pain management, assessing pain, managing pain, would remain the same for every disease that we encounter, every kind of pain that we encounter. So if you think, if you are if you are having a patient with musculoskeletal pain, you have to take into consideration the NSAIDs, and as it is a somatic kind of a pain, please go for NSAIDs and then escalate the maybe the doses to an acceptable level of for that patient. And if not, do feel free to use adjuvant analgesics like the muscle relaxants and other medications. Do also take into consideration the the non-pharmacological methods, for example, the cold compress methods or the heat application. Many musculoskeletal pains also, I've seen patients of such pains who respond to something called the radio frequency ablation also. So please feel free to use those. And at one point of time, you may consider using weak opioids in combination to step 1 drugs also. So I would suggest.
I also do is, you must remember that in patients with airway disease or respiratory diseases, they could be on inhalers, and inhalers definitely cause hypokalemia. So please insist that these patients take banana or something to replace their potassium. Other thing that you can do is also to see to it that you can try using magnesium oil. It has really worked well with my mother with cramps. So magnesium oil works. You can even try, some patients like massages, some patients like hot and cold, like Sanghamitra said, but respiratory diseases with complaining of cramps, please tell them to insist on including potassium in their diet, because the inhalers can definitely make a difference in the electrolyte disturbances. Also, please check whether the patients are in very hot places, if they're adequately hydrated, etc., or very cold places if they are adequately warm. So that is also very important. Anything else? One more question is, in COPD, important cause of pain is right ventricular affection. Yes, very true. So the idea of this class also is that the situation in which we meet these patients are to palliate the symptoms. So you should have a disclaimer that you might not be able to get to the bottom of the full pain. You have to try the non-pharmacological and the pharmacological reasons, including the side effects. So you cannot prescribe opioids without laxatives, because your patient is going to be even more dukhi after that. Second thing is that you also need to please remember at the end of this entire session that you need to address the total pain of the patient. The pain need not be contributed only by the physical aspect. It could be a lot of emotional, psychological, financial, which we are not trained to think. We only focus on the physical aspects in our training. So sometimes you can say, is there something else bothering you? Are you anxious? Are you not coping? Do you want to talk to me alone? And there may be a lot of things that can come out where you can address the patient's pain. Yes, it is not the purview of chest physicians. I don't want you to waste your time saying, here, now this woman is going to tell me to spend 20 more minutes with the patient. No, identify, acknowledge, and tell the patient, yes, I can see that this is causing distress. If you allow me, I'm happy to help you. Either you have a palliative care physician, or you have a counselor, or you have a psychiatrist, somebody who is going to sit and talk to your patient. So please recognize that all issues with your patient is not necessarily respiratory or physical only. There can be a lot going on in the house. He might be treated like a burden, ki 10 saal se bimar hai, you're not getting better, my job is at stake, my family is at stake. So many things. Magnesium oil is what we use. It's easily available on Amazon. Okay, and there's another question here. 1 minute, Sanghamitra, which is
I think
to consider hot and cold. Actually, according to me, Sanghamitra, do you want to take that? When to consider hot and cold? It also depends on where the patient is, what makes it different. So, but the ideal thing is, any acute injury, cold works better, otherwise hot. But you can see some patients have preferences, so can be trial and error.
Yeah.
Kiran Vishnu has said, in the previous classes, opioids were said to be ineffective in post-traumatic chest wall injury and rib fractures. Due to the perceived type of NSAID-induced injury from nephrologists, we are in fact scared to give NSAIDs in spite of knowing its benefit. Could you comment, Sanghamitra?
See, that is where I have actually tried to show the myth and the facts, So when you know the benefit, you must not actually see, we practice evidence-based medicine. So I would definitely go for anything which is beneficial for my patient and effective for my patient. So I don't think there is a dual thing here. I will not think twice, because when I know the benefit, I'll definitely use that. That is my comment.
There is another one which Sunil has actually answered. Could you describe how to convert oral morphine dosing to a fentanyl patch? What would be equipotent dosing chart? How would you titrate the patch dosing? So Sanghamitra, you can take that briefly, but if there's a link, Sunil has already answered it. But if
Yeah,
there's
I think Sunil sir has actually given the best answer. So I think that's a self-explanatory answer here.
Yeah, true. If there's anything for them to read further, you can share the link with Pallium. We can send it to all our participants.
Yes.
And the other thing, my one takeaway from the pain class, which I attended first in 2016, when I was still new to palliative care, is when Dr. Rajgopal said about NSAIDs, that we forget to tell our patients about drinking water when they take NSAIDs.
Yeah.
So small things. Hydration is excellent. It is not that NSAIDs is bad. You take NSAIDs for 10 days, you'll get adrenal failure. It is also the fact that you need to take care of the acidity that some patients get. So you need to co-prescribe that. And you must tell patients, please drink lots of water so that it gets flushed out well. And bottom line should be patient comfort. We need to focus that the patient is the center of our treatment, and therefore see to it that we give necessary precautions to them so that they don't end up getting side effects. I know it's drilled in our heads about NSAID side effects, but if you give adequate water, see to it that the patient is given proper instructions, we don't see that many. How long would we give morphine? Long-term side effect, endocrinopathy. Kiran Vishnu has asked Sanghamitra. How long?
How long? So morphine doesn't have any ceiling effect. We need to understand that. Morphine doesn't have a ceiling effect, and you'll find you can actually de-escalate the dose once the pain has stabilized. You can try to withdraw morphine also. There has been instances where the pain has been stabilized and we have withdrawn the morphine after. As I said, it is important for you to review. It is not that we'll be sending the patient home after giving 1 month of morphine and not reviewing the pain after even after 2 or 3 days. So it is important that we will review the patient once the patient is on pain medication, whether it is morphine or it is something else. And then when we find that, yes, the pain has been constant with this particular dosage, can we start reducing the dose, review the patient once again, reduce the dose. And if it is important for us to stop stop morphine and de-escalate to step 2, we will do that also.
Correct.
That is good.
And the other point here is that it's like Sanghamitra emphasized on review. Your patient might not even be better on morphine.
Absolutely.
So that's even more important, that when you start a new medication, be it any medication, it's important to get a feedback, because patients may benefit. There is a chance patient may not benefit. All the more reason that patient who does not benefit should report back to you, because then you can assess and explore more as to what the cause of the worsening pain is or not fading pain is. So review is very important. Only thing that, because morphine is an opioid, essential narcotic, we are a bit more cautious. So very important is not that you prescribe morphine once, it is for lifelong. So review is essential, and it's also responsible practice to review these patients.
And at the same time, you always need to, be vigilant about the side effects and the adverse effects. If you see that the patient is, having drowsiness after, maybe after escalating the dose or on the same dose, that might be an indication that your patient is having more of the doses that is required, and you will need to decrease the dose. So always be vigilant about the side effects and the adverse effects.
Great. Any more questions? Hema has asked, need we taper and stop? Of course, if there's not indicated, how many times have you come across misuse of morphine?
0 in my lifetime.
again, this is a good question because the
Yes.
West has gone through an abuse of morphine and they use it like, M&Ms and gems. So there is a huge issue in the West. Unfortunately, in India, we use, despite being a good producer of morphine, our patients are still dying in agony because of the lack of awareness amongst physicians, opioid phobia amongst patients, caregivers. And in the illicit market, it is not easily available. It's like, in Bombay city also, there are only 3 or 4 chemists who stock it. In the illicit market, there's also, it's getting a bad name, but the point is we have to use it in a manner which is beneficial to our patients and not for all kinds of aches and pains. So assessment, very important. Review, very important. Follow up, even more important. Taper and stop if it is not needed. And sometimes when I have told this in my talk in the beginning, the first talk, that when patients are given opioids and the patient eventually dies at home, especially during pandemic, then specific call when they announce the death of the patient is to flush the opioids down the drain. We don't want it to go into somebody else's hands, because during the pandemic, it was very difficult to actually get back the opioid and all of that. So these people used to buy it privately from the chemist. And also it was important to tell patients of how to dispose it if the patient is no more or doesn't need it anymore. Could you describe the tapering schedule for morphine?
Okay. Well, there is no such schedule because again, you will need to perhaps look at the escalation schedule that you have done. If you have, escalated by 5 milligrams, then you'll need to de-escalate by 5 milligrams. That is how I would personally do it. And as I de-escalate, I will actually, ask the patient about how he is feeling about the pain, how much is the intensity, what is the quality. I would again try to review it and then de-escalate. It has to be a need-based thing, and has to be a subjective for every patient, has to be tailor-made for everything.
Okay, I think we should go on to the case presentation. If we could ask Dr. Shirley to share her screen.
Good evening, everybody. Am I audible?
Yes, Doctor.
Yes. Okay. My patient is not able to, okay. My patient is a 38-year-old male. He came to us with the pulmonary and abdominal tuberculosis. He had a small bowel perforation. He also had progressive breathlessness and worsening lung functions. He presented to us with nil urine output for a day, constipation and not passing flatus for 2 days, breathlessness for about a month, abdominal pain also for a month, fever on and off for 6 weeks, and fatigue for 2 months. He had not been able to go for work for about 2 months due to fatigue, and he had low-grade fever on and off for about 6 weeks. And his breathlessness on exertion was there for a month, which increased since the 2 weeks before he presented to us. And he had abdominal pain for about a month, which was increased in intensity since the previous 2 days. He had constipation and he had not passed flatus for 2 days. He had not passed urine for a day. When we saw him, he was conscious, oriented, he was responding. He was very poorly nourished. He was severely dehydrated. He was febrile. His BP was just barely recordable, 70/50. Pulse rate was 120. And respiration was labored breathing using all accessory muscles. Bilateral lower zones decreased air entry. And room air saturation was 92%. Abdominal guarding, rigidity, and generalized tenderness was present. These are his parameters. When he came, his HB was quite low and counts were high. Platelets were also only 63,000. And creat was high, probably because of the dehydration of the past 2 days, which slowly normalized within the next 2 days. Next, please. CT abdomen showed a bilateral moderate amount of pleural effusion with subsegmental lung collapse. There was free fluid in the abdomen pelvis, and bilateral extensive tuberculous changes were seen. So we went ahead with a laparotomy under high risk consent and taking all precautions. The surgeon couldn't do much because the bowel loops were quite adherent. The tissue was very friable. They couldn't separate and mobilize the bowel loops. So the perforated part of the ileum, they could just do an ileostomy. It was a picture of tuberculous abdomen with intestinal perforation. So over the next few days, we could give him only enema wash for the bowel wash, potassium correction and supplements needed, nasogastric feeds to give the anti-tubercular drugs, and ileostomy care, bedsore care, and Paxil transfusion to improve the hemoglobin. He was maintaining saturation with just nasal prongs oxygen by 2 liters per minute. So he was maintaining around 97-98%. So the physician was not very keen to intubate and ventilate him. Also at that time, we did not have enough number of ventilators, so we could not use it for him. And though we referred, the relatives were too poor and they could not go elsewhere for treatment. Next, please, ma'am. We had started on anti-tubercular drugs, all the rifampicin, pyrazinamide, ethambutol, streptomycin, also low-dose steroids, and piperacillin, tazobactam for the infection, with pain relief with paracetamol and tramadol. We do not have morphine, so we used only this, ma'am. He was a daily wage laborer. He's the sole breadwinner of the family. And past 2 months, he was unable to go for work. His wife and 4 minor children are dependent on him. And his brother was bearing the expenses. He was also scared of how his family will fare in the future. And his wife was just too overwhelmed by the illness and not able to comprehend what to do. The children were away at home in the village. Next, please. Main concerns were his worsening lung function. The pleural effusion was treated with limited amount of tapping. We did not put a chest tube. We just did a single short drainage of around 200 ml on one side, and 2 days later around 200 ml on the other side. And GI TB was there with peritoneal soiling and adherent bowel loops, so there was not much peristaltic movement, and his oral intake was also not really possible because the bowel loops were all adherent and it was like a frozen abdomen picture. So the patient was not showing much improvement, and he deteriorated quite slowly, possibly because of the sepsis, the underlying malnutrition, and all the comorbid illness. And he succumbed to the illness within 2 weeks of admission to hospital. So in summary, a 38-year-old man with pulmonary and abdominal tuberculosis, breathlessness, and worsening lung function. So we were just wondering what else could have been done for this patient and his family. And the treatment which we gave for him, we do not know whether it was curative or palliative, but that was what was available and that was what we could do for him. Yeah, so that's that. Thank you.
So now that we are at the end, thank you, Dr. Shirley. First of all, I think losing a 38-year-old can be very, very sad. And secondly, due to TB can be even worse. And I know that in India, we still have 1 patient dying every minute of tuberculosis between the age of the productive age group between 15 and 50, which is really sad. So yes, you highlighted a very important aspect of tuberculosis and palliative care. And in a country like India, that is something which is completely neglected. Even especially when you have deaths due to tuberculosis, imagine the amount of bereavement issues that patients and family have to lose young family members. Also, when we have the dangerous varieties of tuberculosis like drug resistant, multi-drug resistant, extra drug resistant, and totally drug resistant. These are all such scary terms. Also because the treatment is expensive, treatment is prolonged with a lot of side effects, and a lot of the family's wealth and financial status is in question. So it is a very important fact that you highlighted about TB requiring palliative care, and it's extremely important to start teaching your residents about, because TB still has a social impact. Stigma, sometimes patients with cancer get an emotional support. Patients, TB still is HIV, TB, these are conditions which are still like thought as, oh, you have TB, you have to be, put aside type. So it's sad that there's so much stigma, and in a lower socioeconomic strata, it gets much worse. So I want the group to tell us where could palliative care integration have helped this patient, and what all could we have done as chest physicians, to treat this patient of tuberculosis, because it has to be, I mean, we are now at the end of our sessions with palliative care for respiratory physicians, and this was a good case to end with, because it really starts us thinking as to what we do in the OPD. Are we just there to write medications and say tata bye bye to the patient, or we also explore how these patients are coping in life, and also their caregivers, which is an important integral part of palliative care. So, or any of you, if they can unmute or send chat messages of how we could have helped this patient. So again, to reiterate that palliative care is not based on diagnosis. It is not just for cancer. It is not just at end of life. It is need based. Very, very important. It is not based on diagnosis or prognosis. One family is clearly not coping, needs palliative care, whatever the diagnosis is. Sometimes there are families who cope a lot even with the gravest diagnosis, but it is need based. And the importance of palliative care is the variety of issues it covers, which is physical, emotional, psychological, spiritual, financial, social. So many things can be done at all levels. And I think that's the beauty of palliative care, that it is multidisciplinary. It is not I, me, myself. It is not just doctor driven. The nurses, the psychologists, the physios, the volunteers, the caregivers, they're all a part of this. It's important to support our patients and family. So any of you want to, suggest of how we could have treated this patient with palliative care integration? We are not going to meet again soon. So it will be nice if you all can put on a video and we look at your beautiful faces and you all interact with us. Anybody? Shirley, do you only want to start now with your palliative care knowledge as to how you could have made a difference, or how you will in the future?
Maybe giving him morphine would have helped with the dyspnea, and it would have reduced his work of breathing. Yes. So a small dose of morphine would have helped that way.
Excellent.
Anybody else? Okay, maybe we could have added total parenteral nutrition, TPN, but how many days it would have helped, we don't know.
That have helped him? The TB was going nowhere.
Yeah.
So it would have just made him poorer and the family on the roads. So, you need to balance benefits and risks of a potential. See, for example, if you have a patient who's low in albumin, end of life, ascites, there's no sense giving that patient albumin. You rather save that. I mean, it's money. I'm not saying money shouldn't drive your decision making, but at the same time, it should also be logical. Is it going to improve this patient's quality of life? Because quantity though is not there. He is going to die of the illness. So does TPN really make a difference? So I think the way we can think of palliative care is ideally whether he could have in the beginning received adequate support financially, crowdfunding, refer him to trust so that he can take the medicines. It starts from the first time he's diagnosed TB, right? You need to give that complete speech to the patient about the importance of taking medicines, when to take medicines, side effects of the medicines, not to stop, report back for side effects, duration of the treatment. Very often if you see, especially where I trained in the public hospital, AKT was always followed by MVBC, pyridoxine, iron, this, that. And patients used to think, I'm taking medicines. How does a patient know which is TB medication, which is supplements? Supplements didn't give him side effects. So he continued the supplements and he stopped the TB medication. So it's important to educate patients. The speech that you need to give that these 4 are TB medications, these 4 are going to cure you, these 4 are supplements. So if you have a problem with these 4, vomiting, nausea, report back to us. So what I used to do in Sion Hospital is all the new TB patients, I used to gather them in one circle and give them the same speech, so that I don't repeat myself and I don't have the time to do that to 500 patients, all of them. So the 10 patients who are new TB, collect them all together. Then I used to train my registrar, and registrar used to give that bhashan. It's important to tell them that 4 medications for 2 months, 2 medications for 4 months. Because the minute you start feeling better, like I always feel, none of us have taken amoxicillin 3 times a day in our lives. We have all cheated. So if we cheat, our patients will cheat. Educated doctors don't take amoxicillin course 5 days, 3 times a day. So patients will cheat. We really need to emphasize that this is TB. If you want to get better, this is what it is. And you can also give your family members. So the way to put fear in them is how to take the treatment, how to see to it that you come back for follow-up. Don't stop when you're feeling better. Stop when I tell you to stop. So that is one very important aspect. Second thing, of course, is how we could have supported this patient financially. I mean, there are trusts, there are rich people, there are charities. So to encourage that. Also to see to that his family is supported, like kid is not dropping out of school, wife has not stopped working because he has to look after the husband, so many things. And another important aspect is bereavement. Are they coping after death? Palliative care doesn't end with death. We almost always, that is a part of palliative care, is bereavement care. Yes, we cannot change the outcome, but are you okay? Do you want anything? Is everybody else in your family okay? Is somebody going through complicated grief? Or if somebody is unwell, let us know. We can send you to the right doctor. So it's important, because you and me will appreciate that kind of support. So our patients will also do the same, isn't it? Anybody wants to add something?
Excuse me,
Yes, Radha.
if there may be some government setups to help these TB patients, if we can, because I used to use a group when I used to be in India called Reach. So like those type of people will help you to give the full drug supply. And even some, so I'm not sure exactly where Shirley is from and whether that type of setup will be there, but there being still a very significant disease, there may be some government setup which will give the medications and some part of the burden may be taken off. Now the wife being a close contact has to be followed up. So that is an important thing. He would have been an active case, and then in that case, she would have been in close contact, following her up and making sure that the next 4 children, those are things. And one of the thing what Dr. Rajan I have mentioned is very important. We are not like using the money properly. See, if you exhaust the money, then that wife and 4 children will not have anything to live.
True.
So that is where palliative care, and we have to be just not as doctors, as human beings, think for that. So we will do always correct the correctable and do 200% for something which can be treated and not drain the money from someone who needs it for the rest of the family.
So that is
Even
the
in wealthy people, we have seen this. That is why
it's
is
very
something.
sad that the rich also don't get good logical treatment. We continue to give them treatment because they're rich. They can afford. They are not going to complain. So this is
No. I've
justice of
seen a
medical
personal
ethics.
experience with like one of our superintendent who was very sick, and in that stage he had only one child, and then you can't keep on. He went into private care. Only it was draining the money because his outcome. See, you cannot. You have to face and prepare the patient to face the inevitable. It's not that we are scaring or doing something. Try to tell it in a nice way, being logical, and the inevitable cannot be stopped. None of us can stop.
Correct. And the continuation of what Radha is saying is you need to give them realistic hope, and you need to be there after breaking the bad news. You cannot abandon them. So it's very important that you tell them this and say, look, I know this is sounding very bad. I know this is looking difficult, but I will be there to support you. Me and my. So it is, instead of that, we actually shy away from the truth. And then I think all the mess starts. And it's important, therefore, to give them the realistic hope and be there for the patient. And that is the beauty, again, of palliative care, because it's not just the doctor, but so many people can be in touch with the patient and the family.
And that will have a good out. The patient will come back to you. You don't hurry them. Tell them, take 5-10 minutes time, think and come back, and I am there. And always you say that, don't worry, don't think that I'm just going to, and as Dr. Rajam said, we do follow palliative care, bereavement, and we follow up the patient after some time. That's when we collect the morphine back. When we start telling them all this, see, even though the patient may not be aware, as doctors, we will be aware. We can't say date or something. We have seen the patient in such critical condition. So slowly preparing them and being for them will gain their confidence in us, and they will come back to you. And they themselves will say, okay, we understand now. Okay, you tell us what to go do from now on. So it is going to be beneficial for them. That is how we have to start.
I like the way Radha says slowly, which means we need early integration of palliative care, because we need time with patients. Patients may not have that time for them to process and analyze. So the earnest request is early integration. The more time, the more prepared, the less frazzled they are in an emergency. Going with the same point, rather, there's a question from Kiran Vishnu, or rather a comment saying that management support should also be realistic. Dr. Stephen said she did her best. Here, the disease was extensive, but he also says, I want to actually ask him what he means. I would have advised on nutritional support also here. So what does that mean? I don't know. Kiran, do you want to clarify? And Dr. Bhargaji has said, yes, I have actually managed to, my purpose is served. Palliative care is not cancer. Palliative care is not end of life. It's need-based. So everybody who has an issue, who is not coping, requires palliative care. Hema is saying what was done was what was required. Educating the wife about TB and screening is the only way to prevent. Then Kiran has written, we all look upon steroids as a last resort. May have added something here, taking adrenal insufficiency here. A discussion with his brother. Yes, thank you, Kiran. Government gives, okay. Bhargaji said, yes, patient gets drugs, nutrition support relatives also get screened under AR. Yes, thank you. So, Kiran, I want you to pick your brains on what you mean by we will give nutritional support before we call it a day. It's just your thought process. We just want to know where you're coming from.
But a nutrition
Why
support
would you have given nutrition here? And when?
When early on.
Yeah, true. Yeah. Early on, he would have needed everything: nutritional, psychological, vocational, financial. Yes, but at end of life, to waste his little bank balance is probably...
No, you don't have to waste the balance, madam. It is always available in the hospital. I think whatever available in the hospital should be given, ma'am.
Sure, but not to, again, you need to use, we have not got unlimited resources in the hospital. We should not be giving to a patient who is going to die in the next 24 hours.
Yeah, I would always advise against buying protein powders and everything.
No.
I think whatever is available, you could utilize
the hospital resources, Dr. Vishnu, we need to justify the use in a dying patient, right? There are patients who are going to survive. We should use on them. We have to use we don't have a pot, which is like Akshay Patra, where we can keep giving the whole world. If that was the way, then India would have not been the way it is. We have limited health resources. So justifying the use, and that is why I feel that even in a public hospital, there is logical treatment given to a patient, not illogical sometimes like in a corporate hospital. The patient can afford, give, patient is not complaining. That's not the point, right? So I just wanted to clarify that. Anybody with any comments, anything at all? Dr. Biju, do you want to add something? I can see Dr. Biju here. Sanghamitra is saying, yeah, what is our goal? Exactly. So we need to realize everything has to be justified. Yes, Dr. Biju, nice to see you.
Same here. I was just intrigued by the nutritional part. Perhaps there must be some reason behind saying about that nutrition. If we could get some clarity on that part.
So I think he meant it to be given earlier on, which is correct. He also added saying that whatever is available in the hospital, I'm not going to get expensive things from outside, but even the hospital. So my argument was that even in the hospital, we have limited resources. We should use it judiciously. But I have also noticed this, Dr. Biju, that very often nutrition does become a challenging point for end of life. Relatives don't want to stop. Patients are not even aware whether they're being fed or not. Doctors also find it very difficult to advise do not feed anymore. So nutrition becomes, it's not accepted as the same spectrum of ventilator, stop withdrawing and withholding. Somehow nutrition doesn't feature in that at all amongst physicians. So would you like to add?
Okay.
Yeah.
Yes. What usually happens is that when people are terminally ill, this anorexia, cachexia kind of takes over. And as a result, patients become anorexic. Uh, there's a progressive loss of appetite, progressive loss of weight, progressive loss of strength. And the family gets mighty worried. And their attempt is to somehow feed the person and try to get the person back into health. So it needs a bit of counseling the family primarily, because patient is fed up of the family trying to feed them. So because of usually a lot of my effort goes into counseling the family, making them understand. I use a few things, like for example, I tell them that the patient is uh, not hungry because of the disease is progressive and advanced. And so let us focus on comfort feeding rather than feeding to improve the health, because improving the health is not going to be possible. And what does comfort feeding means? That means let the patient have whatever he or she wants, whenever he or she wants, in whatever quantity he or she wants, but don't force it onto the person. Then I tell about why it is important not to force, because let's say if you had a full meal and on top of that you are made to eat more, so that is, you are made to eat more than what your body can tolerate, then you are likely to experience a lot of distress, abdominal pain, discomfort, nausea, vomiting, unable to sleep, can't breathe. Especially, we have a audience of pulmonologists here. So a lot of physical distress comes into play, and that is not because of the disease. It is because of the love and affection of the family uh, caused by force feeding. And if this continues on a regular basis, the patient gets frustrated, angry, feels helpless, hopeless, that nobody's going to listen to me, may go into depression. Just the sound of cooking or the smell of food may make the patient more anxious. So the patient suffers physically as well as emotionally. This can have an implication on the relationship. The patient and the family may get into friction over the food. There might be a food war going on in the household, where the family and the relatives and the neighborhood and almost the whole world is on one side, somehow trying to feed the patient, and usually the patient is alone in a losing battle, uh, trying to limit how much he or she wants to eat. This can also lead to aspiration pneumonia, because when you force feed, there's a high chance of aspiration. Another source of aspiration is if patient is on Ryle's tube, and usually people don't realize it, but they put the patient on supine instead of raising the head end at least 30-degree elevated 24/7, even when the patient is not being fed, because the stomach is never empty. There is acid in there and digestive enzymes. So you can have chemical pneumonitis because of aspiration of acid and things like that. So even if the patient is not being fed, the head end has to be elevated. This is to prevent aspiration. So many times force feeding will cause physical suffering, emotional suffering, relationship suffering. You denigrate the patient's dignity of life by forcing things on the person that the patient does not want, and end up causing aspiration pneumonia. And the patient may have could have lived longer and in more comfort only if the patient was not force fed. So we are not saying don't feed the patient, just we are saying that Let the patient decide when the patient wants to eat what in whatever quantity. In Malayalam, I say ishtapettu kadikka, kashtapettu kadikkinda. It kind of translates to khushi mein khao, khushi se khao, kasht leke mat khao. That kind of something like that. So yeah, it's a difficult thing because food has a lot of emotional connotation, social connotation. So some kind of counseling is required, and usually people understand this part.
Thank you, Dr. Biju. Thanks, Dr. Sanghamitra. It's lovely to see old friends. It's high time we meet in person. And as I was typing in the messages, thank you all for giving us this opportunity to get palliative care across to respiratory physicians. It's my dream project, and I really hope that with the help of Pallium, we can do more such sessions and get in touch with more and more respiratory physicians. And we really hope you have also enjoyed these sessions as much as we have, bringing it to you. I would request Rajalakshmi, if everybody is decently dressed, to put on their videos for having a picture as a record, and also then to say the thank you from the Pallium side. And we really hope that you tell your colleagues, friends, and residents about such a program, and let us know, keep in touch with us, how this has benefited you in your clinical practice, and all the shabashi and accolades you get from your patients, after listening to the small what do you say, small nuances that we have taught about polishing your respiratory medicine. So thank you very much, and over to you, Rajalakshmi. I'm not very well dressed, but I'm still going to smile with all my teeth.
Thank you, Dr. Rajam. So it's smile time now. So I request all to on their videos. So just taking a screenshot. So 1, 2, 3, go.